Hi, this is Dr. Bueller, and we're going to talk about our third and final class of viruses, the DNA viruses, and the associated antivirals. The DNA viruses are viruses that contain DNA as their genomic material, and in these examples, they're going to have to replicate their double-stranded DNA to identical double-stranded DNA inside the host cell. There are several different DNA virus families that cause disease in humans. We'll be talking about the Herpes Virus Family, HPV, human papilloma virus, and HBV, which causes hepatitis B. So it's really important to think about the relationship between these DNA viruses. We have HepB, which causes liver disease. We have human papilloma viruses, which cause different forms of warts, sometimes leading to cancers. And these are not closely related to the herpes virus family. Within the herpes virus family, though, we have several different viruses that are very closely related. All of these are herpes viruses. Sometimes that becomes confusing because the Herpes Simplex virus is named after the larger family, while the others aren't. All of these are DNA viruses, and DNA viruses can insert their DNA into our DNA, and because of that, that viral DNA can become a part of the genomic expression of our cells. During an acute active infection, there's active replication of that virus, and you're going to see the symptoms of the acute disease. Later, however, the virus can stop expressing, becoming latent inside the host cells. At a future point, sometime maybe when we're immunosuppressed, sometimes seemingly randomly, the virus will become replicating again and reactivate the disease state. In the chronic form of expression, sometimes the symptoms can actually look somewhat different than they did in the acute form. So this is an activity that you can do to see if you can figure out which vaccines are for which diseases just from the names of them. And this will end up being very helpful for you so that you don't have to memorize or rely on memorization for these vaccines. With only one exception, our only drugs for these DNA viruses are viral DNA-dependent DNA polymerase inhibitors. Luckily, we do have vaccines for most of these, and we'll be taking a look at those as we go on. So we're going to start with the herpes virus family, looking at herpes simplex virus, Epstein-Barr, varicella zoster, and cytomegalovirus. So herpes simplex virus has subtypes 1 and 2, and these can both cause oral and genital herpes. It's commonly believed that these subtypes cause either oral or genital, but that's not true. They can both cause both. The acute or initial infection symptoms are going to be lesions in mucous membranes, so we're going to see those oral or genital anal lesions. The chronic infection looks fairly similar, although the virus is latent within neurons. When it does come out, it's coming back out in those mucous membranes and does look like those acute lesions. Varicella zoster, which is the name of the virus, can cause chickenpox as the acute disease, or it can cause shingles as the outbreak to the chronic disease. When we're talking about the initial or acute disease and we're talking about chickenpox, we call that varicella. So that's named after varicella zoster in that way. The chronic infection, which also infects neurons, reoccurs in what we call shingles, and shingles are referred to as zoster. So the zoster here. We can also see symptoms of postherpetic neuralgia. So varicella and zoster are both symptoms of the same virus, the varicella zoster virus. We also have Epstein-Barr virus that is responsible for mononucleosis, and cytomegalovirus, which causes just an acute viral infection symptom in healthy people, but if immunosuppressed can cause far more serious concerns. And again, these are all DNA viruses, so they can all produce a latent infection as a result of integration of their viral DNA into our DNA. So I always show you a really complex viral life cycle for these really important viral infections. But as far as the DNA viruses, even though they're as complex, if not more, I have to just tell you that we don't have that many drug targets. We do have one target for HPV that blocks fusion, but every other drug we have is simply a nucleoside analog DNA Pol inhibitor. So while there are groups that are investigating all of these different drug targets, And while I hope you've learned enough about those different drug targets as they occur in other viral types so that you understand new drugs as they come out, we don't have a lot to work with here. So I am going to ask you to please watch this life cycle video for this DNA virus. It's only 5 minutes, so just go ahead and watch it so that you can compare it to the videos you've already seen of the viruses in the other classes. But we're not going to go through these, and I'm not going to be testing you on any of this. So of the herpes virus family, the first one we're going to talk about is herpes simplex virus, which is HSV1 or HSV2. And again, these can be spread to either side. So they can both create oral infections or anal genital infections. The acute symptoms that you see are lesions, and when they're on our lips or our mouth, we often call them cold sores or fever blisters. Similar lesions can occur anal genitally, and these lesions can be very painful regardless of where they are. In a chronic infection, where there's latent infection where the DNA is inserted into our DNA, the specific cells that are being infected are neurons. Then when someone's immunosuppressed or stressed or any other reason that causes the host cell to reactivate expression of the viral genes, lesions can then reappear. We don't have any vaccines for herpes simplex virus, and it's very common. When they just measure HSV1, over 58% of adults in the US are infected, and that's because it's pretty easy to spread. All it needs is skin-to-skin mucous membrane contact when someone is having an outbreak. So a diagram of how the latent infection works for herpes simplex virus and why you can have these cold sore outbreaks later. Out here is the mucous membrane, whether it's anal, genital, or oral. And then here is the inside of the body where the neuron cell bodies are going to be. So these neurons are going to innervate out here in the skin. And when an infection occurs, that virus actually enters the axon of that neuron. So that's really different from what we're used to seeing when we're looking at viruses entering through the cell body of their host cells. So here it's entering the axon. It's actually physically traveling up through the axon into the cell body. And at that point, it can integrate its DNA and produce a latent infection. Out here, you do have infection of the mucous membrane cells as well, but they're not the ones going to be harboring that latent infection. So now you're going along, you go for a year, you go for 2 years, then finals come. You have that immunosuppression due to stress and poor diet, and the cell begins to allow replication to occur. So now that replication occurs here in the cell body, and then the virus is transported all the way down the axon, back to the axon terminals here in the mucous membrane tissue, and then re-released. So I think this is a really fascinating way for a viral infection to work, in that it really travels outside of the area that appears to be affected during an acute infection, and then travels back up in order to produce the lesions that we see. So the drug class that we have here for herpes simplex virus is just a membrane fusion inhibitor called docosanol, or Abreva. And it's really amazing because all it is just this really long lipophilic chain. And the mechanism isn't really highly described in the literature, but it probably acts along with the mechanism of other inhibitors, of other fusion inhibitors that work by changing the fluidity and changing the curvature of the membrane. So when the two membranes come together to endocytose, you have to make a curve, and then you have to incorporate those membranes together. If you've inserted an agent that physically doesn't allow that curvature to occur, then you're not going to be able to have fusion. We use this specifically for herpes simplex virus, and it's given OTC in a topical cream. We don't see serious adverse effects, and that's probably due to the fact that it is used topically, so there's very little systemic activity. So now we'll talk about VZV, or varicella zoster virus. It's also in the herpes virus family. Acutely, you see chickenpox, also called varicella, and those are very itchy little spots that you see on the skin. Once that acute infection and the symptoms go away, the varicella zoster virus can also incorporate into infected cells. And again, this is also infected neurons. So just as we saw with herpes simplex virus, then when someone's immunosuppressed, their cells may allow replication of the virus, and like the herpes simplex virus, it's going to come back down the axon of those neurons and erupt where the axons terminate. Now, herpes simplex virus was infecting the mucous membranes, so it was infecting the neurons that were innervating the mucous membranes. So when you had a reactivation, the symptoms that you saw were lesions again in the mucous membrane. With shingles, you can see with the fact that chickenpox goes through your whole body, that neurons in any part of your body could be infected. Usually, interestingly, there are only 1 or 2 nerve roots that become infected and have the latent infection. So when someone's immunosuppressed and they get shingles, the reactivation of that virus, you can usually tell exactly which nerve root was holding that infection because the rash will come out specifically where that nerve innervates. So we call that reactivation of the virus shingles and also call that herpes zoster. So remember, the virus is varicella zoster, and the first thing that happens is varicella, which is chickenpox, and the second thing that happens is zoster, which is shingles. That's the best way to remember it. But they're both caused by the same virus. Shingles can be extremely painful, but you can also see an issue that isn't necessarily visible to the eye. People can have nerve damage from the infection outbreaks, and that damage to those infected neurons can cause post-herpetic neuralgia. And so neurons and algia for pain, so nerve pain. And even after the visual symptoms are gone, that post-herpetic neuralgia can cause burning pain for quite some time. We do have 3 vaccines available, so we're really lucky there. We've got a live attenuated vaccine that's marketed as Varivax for children, and that's marketed as a vaccine against chickenpox. And then we've got 2 vaccines that are marketed for the elderly, and those are marketed to treat shingles. And those are Zostavax and Shingrix. Zostavax is also live attenuated, and Shingrix is a recombinant vaccine that includes a single glycoprotein that's found in the outer shell of the varicella zoster virus. So the difference between Varivax and Zostavax is really only based on the dose. They're the exact same live attenuated virus. They're grown in the same vat, but Varivax is going to be at a lower concentration than Zostavax, which is a higher concentration. And if you are worried about someone who's immunosuppressed and you don't want to give them a live attenuated vaccine, then the Shingrix vaccine, which is recombinant, has the benefit that it cannot infect a patient. So varicella zoster infection is very common. Over 90% of the adults in the US have had that infection, usually as children in the form of chickenpox. Now that we have a chickenpox vaccine that we give to children, hopefully that percentage is going to keep dropping as those children now aren't going to be getting chickenpox to begin with. And it's actually reasonably easy to spread. It can spread through the air, and it also very commonly spreads in fluid from the blisters. So now I said that we had very few drugs for any of these DNA viruses, and the drugs that I'm going to show you here are going to work for most of the viruses in the entire herpes virus family. So remember, we talked about HSV, Herpes Simplex virus, varicella zoster virus, and cytomegalovirus. These are going to work for all of those. Unfortunately, it doesn't work for Epstein-Barr, and its DNA pol is just a little bit too different. So these are acyclovir and valcyclovir, or Valtrex. And Valtrex is just a prodrug of acyclovir. As I said, these are DNA pol inhibitors, and they are nucleoside-nucleotide analogs. So that's why I say they're related to HIV nukes, because HIV nukes are nucleoside-nucleotide analogs that are blocking the RNA-dependent DNA pols in the HIV virus. Here, they're nucleoside-nucleotide analogs that are inhibiting the DNA-dependent DNA pols, but their mechanism of inhibition is exactly the same. So as nucleoside-nucleotide analogs become incorporated into growing viral DNA, and they're going to chain terminate that synthesis. So we're not going to be able to synthesize new viral DNA, so you do not have viral replication. Again, if all this drug is doing is blocking replication, then it's only going to be acting on virus that's actively replicating. It's not going to do anything to latent virus that's just sitting there. We do have a specific adverse effect for acyclovir and valcyclovir, and that is a potential for nephrotoxicity. So we've already talked about the herpes virus family, and the next one we're going to talk about are human papilloma viruses. And these can cause venereal warts, dermatological warts, and cervical cancer. So about 76 to 80% of adults in the US have been infected with human papillomavirus, and it is considered the most common STD. One of those reasons is that it spreads through all forms of sexual contact. It doesn't require semen or vaginal fluids. It doesn't require penetration. It can be spread just by skin-to-skin contact. These can take the form of oral, genital, and anal warts, and in some cases cancers, which we'll talk about. So about 80% of adults have been infected, and about 26% of them have a latent or chronic infection. And any one of these people who has this chronic infection is going to be carrying DNA in their cells and is going to be able to pass it on to someone else. If you're a carrier and you have this long-term infection, you can develop various types of cancers. The reason that happens is the viral DNA can actually regulate the host cell cycle, and it does that in order to increase the lifespan of the host cell. So in some cases, that virally induced change to the host cell cycle is going to just cause replication, like we see in warts, without causing cancer mutations. If, however, you get mutations that cause cancer growth, then if that cancer is in a place that's not readily visible, like the cervix, those growths might not be noticed until too late. So as far as our numbers here, 24% of the US has not been exposed and therefore not carriers. 50% of the US population has been exposed, cleared the virus 100%, no latent virus, so not a carrier. 20% of the US population has been exposed, has latent virus, is a carrier, can pass it on to other people, but is asymptomatic, so they have no idea they have it. And while it's latent and they don't see symptoms, there can still be enough active infection going on to produce cancer growths. And then there's 6% of the population that has been exposed and does have symptoms, and so they can see warts, dermal warts, or genital warts. And because they do have that viral changes in cell cycle regulation, they also can get possible cervical or penile cancers. There are a lot of strains of HPV, and they will infect different tissues, and they'll cause different symptoms. So some strains are going to affect mostly normal dermal tissues, often seen on the hands and the feet as warts. You can also get genital warts. Some strains pretty much only produce warts and have a very, very low chance of producing carcinomas. However, there are strains of HPV that have a relatively higher risk of inducing carcinoma. And like I said, these viruses can change the cell cycle genes, so the ones that are going to produce carcinomas are often going to produce proteins that are going to inactivate tumor suppressor genes and activate growth genes. While the majority of people who have HPV infection aren't going to get a cancer, the vast majority of people who do get cervical cancer, and many of those who get throat or oral cancers, are getting it because of an HPV infection. And while we do often focus on cervical cancers, it is important to remember that it is possible for HPV to create a cancer in any infected tissue. So we had that acute infection, which could be that long-term active infection that you may not notice is happening, but is causing slow growth of cells. Or you can have a true latent infection where the DNA is in the infected cells, not replicating, and then reoccurs at times of immunosuppression. Again, we're lucky we do have vaccines available, and the human papillomavirus family is so huge, and there's so many different strains that affect humans, that they really have to narrow it down to the most important ones to include in the vaccines. So what they've done is really just targeted the most carcinogenic strains, and these are recombinant vaccines. They're going to have the main viral capsid protein from multiple different strains, so they'll have multiple different capsid protein forms, and then insert that into a virus-like particle, which is the vaccination. So hopefully then the body creates antibodies to all of these different versions of that viral capsid protein. So really the main HPV vaccine you're going to see is Gardasil 9, and it's against 9 different HPV strains. And currently the CDC recommends that all children at 11 or 12 years old get a 2-vaccination regime. So an initial vaccine and followed up by a booster. You can still get the vaccine when you're older. If you're between 15 and 26, they say you should absolutely still be vaccinated if you haven't already. However, you will probably need 3 doses because your body's not going to respond as well to the antigen. It's also approved for up to 45 years old. So if you are at risk of getting HPV and you're 40 years old, then you should probably still go ahead and get vaccinated. The adverse effects of the vaccine are just the standard vaccine side effects of muscle pain, swelling, fever. And so far, we have a duration of action of at least 10 years. So that's really good. Now, initially, many parents were against giving it to children that were so young when this first came out. And a lot of reasons that were given were more social reasons. A lot of parents said, my kid isn't going to have sex before they get married, so we don't need to give it to them. Or why are we giving it to a 12-year-old when they're going to be so far away from being sexually active? There was also a stigma against having a vaccine against an STD because a lot of parents said, well, my kid's never going to get an STD. They realized that they needed to explain or market this as a cervical cancer vaccine. And parents were a lot more likely to get on board with vaccinating their girls if they knew that was really going to almost completely get rid of their risk for cervical cancer. However, then once it's being marketed as a cervical cancer vaccine, people weren't going to give it to their boys because they don't have cervixes. So now we've been able to get it commonly being given to all sexes and being given around 11 or 12 years old. And the reason that we really do want to give it that young is we do want to give before the first sexual activity. You don't want to wait until afterward. Plus, for this particular vaccine, the antibody production is much stronger for people under 16 years old. And that's why you came back to this and they said if you're between 15 and 26, you might need 3 doses. So now the HPV vaccine is pretty commonly given and pretty accepted. This is really just a piece of information that I think is pretty useful to have just seen. These are stats from 2016 and these are Oregon stats for 2018. I know these are pretty old, but it's very difficult to get these large statistical studies out quickly, and almost always when you're seeing these large epidemiological studies, they're going to be from a few years prior. But this will show you what I want you to see. So down here are the percentage of girls. So here's 50% of girls who've been vaccinated, 75% who've been vaccinated. And up here, boys, 50% of boys who've been vaccinated, 75% of boys who've been vaccinated, and 40% boys who've been vaccinated. The amount of vaccination in 2016 widely varied between different states. And some of that's social, some of that's medical access. But you can see that down here in Wyoming and South Carolina, about 50% of girls and about 37% or so of boys were vaccinated. Up here at Rhode Island, we've got 95% of girls and almost 90% of boys. And Oregon right here is pretty much smack in the middle. So in 2018, the last data I could get a hold of, when they looked at 13 to 17-year-old kids and whether they'd had both shots, about 50% of the girls had been vaccinated and about 43% of the boys had been vaccinated. And so when you run the stats on that, because more females had been vaccinated, then female-female couples are going to have a higher rate that at least one of the partners is vaccinated. And so that was about a 75% chance that at least one of the partners was fully vaccinated. A male-female couple, there was about 71% chance at least one had been vaccinated. And because boys had a lower rate of vaccination, in male-male couples, there was only about a 67% chance that one had been vaccinated. And when it comes to vaccination rates, you know this isn't terrible if you're in this high 70s or 80s, but it could definitely use some help down in here. And so the last DNA virus that we're going to discuss is the HepB virus. Remember, hepatitis just means liver damage, and there are a lot of ways to get hepatitis. Viral hepatitis is just any disease of the liver caused by any virus. And we've named these viruses based on them causing hepatitis, but that can be confusing because they're actually unrelated viruses, so your treatment for them would not be the same. So Hep A was an RNA virus, as was Hep C, which we talked about, and Hep B here is a DNA virus. Hep A and Hep B have vaccines, whereas Hep C did not. And while Hep A wasn't real dangerous, Hep V can be moderately severe, and Hep C is the most severe. And unfortunately the most common because of those baby boomers. So I want you to remember that although we call them hepatitis viruses because they all cause liver damage, they're unrelated to each other. And because they're unrelated, they can be transmitted differently. A drug for one isn't going to work for the other, and a vaccine for one isn't going to work for another. So, like all these other DNA viruses, we can see an acute infection that looks, in this case, a lot like a general viral acute infection with that fever, fatigue, muscle aches. Sometimes, if it's more severe with some jaundice or abdominal pain or other signal that maybe there's something going on in there. But for most people, it's asymptomatic and it's completely cleared. If it is going to become a chronic infection, it could be for two different reasons. So one reason is it could be a true latent infection where the DNA is in your liver cells. However, it can also be a very slow infection, which is active, in which those cells are actively producing virus, but it's at a low rate so that you're not necessarily noticing it. And again, that's different from the latent infection. With this long-term infection, you can have cumulative liver damage. And we saw the cumulative liver damage from a long-term active infection when we looked back at Hep C. However, because Hep C was an RNA virus, it did not have the latent. So when we look at Hep B, we can have latent infection and we can have that long-term active. Whereas with Hep C, we did not have latent, but we could have long-acting. So we do have vaccines for hepatitis B. We don't for Hep C. And these are recombinant vaccines that are composed of a surface antigen made in a vat. And these are Heplisav, Recombavax HB, and Energix B. And hopefully if you look at these, you can figure out their Hep viruses from Hepsilav, HB for Hep V. And if you remember Energix is hepatitis, then it tells you it's the B virus. This one's also going to tell you it's a recombinant vaccine. All of them are, but at least it's in the name. As I mentioned, there aren't a lot of drugs for these DNA viruses, and the drugs that we have for Hep B are going to be nucleoside analog, DNA-dependent DNA Pol inhibitors. And the one that's Hep B specific is entecavir or Baraclude. So when we look at Hep B, we're coming with this double-stranded DNA, and we have to make new double-stranded DNA. And so we had to have a viral DNA-dependent DNA polymerase. When we looked at HIV, HIV came with a single-stranded RNA and then got turned into a double-stranded DNA. So it needed a viral RNA-dependent DNA polymerase. And it's the fact that these are both DNA polymerases that means if we're using a nucleoside analog that looks like a DNA nucleoside, we're lucky enough that some of the analogs that would go into reverse transcriptase are also going to go into the hepatitis B polymerase. So while entecavir is the Hep B specific one, some of the HIV nucleotide reverse transcriptase inhibitors will also have some activity at decreasing Hep B replication. So if you remember back in the HIV nucleoside reverse transcriptase inhibitors, we had a black box warning that if someone had HIV and HPV and then went off of their nucleoside reverse transcriptase inhibitor, they could have severe worsening of their hepatitis. And that was because those HIV nucleoside reverse transcriptase inhibitors did have some activity at keeping down the Hep B DNA Pol. So when you take away the HIV drug, then that drug is no longer there to keep down the Hep B virus, and so you might get a worsening. We really don't know how many people have been exposed to Hep B because for the most part, it doesn't go into latent infection. And then the main transmission modes are bloodborne or semen or vaginal fluids, but it is a little bit easier to get than Hep C in that it can have transmission with saliva. That's uncommon, but sometimes that's a concern when there's a bite that it could be transmitted that way. So now that you've gone through all of your viruses, we've looked at those nucleic acid polymerase inhibitors that we had for pretty much every virus. When we're lucky, we have other drug targets for individual viruses, but these are really our go-to for antivirals. So those DNA pols are related to each other. So the DNA pols and the reverse transcriptase are somewhat related. Within the DNA to DNA pols, we have the Herpes Virus Family and the Hep B virus family. And within the RNA viruses, we can use RNA Pol inhibitors, and we could use them for influenza, for Hep C, or for COVID-19 if we get ones that work. There may be some crossover activity in some things like Hep B and HIV, but for most of these, there's enough difference in the structure of the Pol that a lot of these Pol inhibitors are specific to one disease only. So I want you to go through and list out all the drugs that you've covered for each of these viruses that act at DNA or RNA pol. And so listing here all the HIV nucleoside analogs and all the non-nucleoside analogs that still inhibit DNA pol, so the non-nukes. I gave you just an example here, and then you're going to fill in the specifics. Okay, thank you for sticking with me through all of the viruses and all of the antivirals. And if you're in my class, you are done with infectious disease. And I'll see you in a later class.